Hi, the last part of this chapter deals with burns, which are very challenging for respiratory therapy to deal with. The epidemiology is that there are yearly 450,000 people that receive medical treatment for burn injuries, and 40,000 of them are hospitalized. And each year, 3,400 patients die due to fire, burns, and smoke inhalation. So it is a very serious problem to deal with. Now, burns are categorized by the extent of the skin, the depth of the skin that's affected. So as you see up here, there's three layers basically. You have the epidermis, the dermis, and then the hypodermis, or the subcutaneous layer. And after that, you have muscle and bone. So there are 4 degrees of burn, and these are the first 3. A first-degree burn would be your epidermis, and you can see what it looks like there with the hand, and then the second degree would go into the dermis, and the third degree going below the dermis to the hypodermis, or the subcutaneous tissue. And that's when it starts to get that dark look to it. And you can read that the third degree is considered a full thickness burn, and it extends into the deep tissues. It causes white or blackened and charred skin that may be numb. The only saving thing here is that the patient is not in pain, because the nerve sensors have the sensory nervous system's been damaged. Then there are 4th degree burns, which actually go to the muscle and bone. Now, they categorize burns this way. They look for the total body surface area that's burned. And so they'll take these, a burn unit will have these sheets readily available, and they will anticipate the arrival of a burn patient. And everyone at that point puts on gowns, gloves, hats, booties, and masks, because the skin is our protection from the world. And so when it's compromised, it puts the patient in a heightened risk for infection. So that's the first thing that's going to happen. And the room will be the very clean, specially dedicated burn receiving room for burn patients to be received in. And this chart will come out, and they will estimate the percent burns that occurred over the patient's body. And that gives them an idea of how sick the patient is going to be. They're going to use that to help regulate the patient's fluids, as well as they need to know how much skin grafting the patient's going to need, and that kind of thing. Burn units, places that have burn units, first of all, the nicest nurses in the whole world are burn nurses. Hands down, they are incredible. And the next thing to know is that the burn unit is on a strict isolation, much like an operating room. And so although the burn unit may be stained with the medications that they use to treat the burns, those walls are sterile. That the unit has to maintain a sterile environment for these burns to be able to heal without infection. Now, the burn comes in, and the first priority is the airway. Are there any signs that the patient has received any injury to his face, mouth, lungs? Because the next thing that's going to happen is edema. And if you have swelling in your airway, it can close off. So they're going to be very proactive on intubating the patient immediately, so that it will be able to be done, instead of having the airway close off and become an emergency or a deadly situation. The patient is considered a trauma patient, and they're going to measure the extension and the depth of the burns, and also the degree of involvement of lung tissue. the lungs are going to be, if there is inhalation, the inhalation could have been toxic, and that is going to cause a chemical burn to the lungs. The lungs are going to swell. They're going to become edematous. You're going to have lichen and pulmonary edema. Also, you have to think of, did carbon monoxide, was that involved? And I think of that in any burn patient, the first thing you want to do is to see how much carbon monoxide they have. Remember, carbon monoxide takes the place of oxygen on the hemoglobin molecule, and therefore you are unable to deliver the amount of oxygen needed to the tissues. So the patient's going to go on 100% oxygen, and you're going to check with a heme oximeter to see how much carbon monoxide is present on the hemoglobin. There also could be cyanide toxicity. Now, cyanide, the oxygen gets on the hemoglobin fine, but it never gets to the cell. So the patient does not get oxygen. They are hypoxic. They have tissue, a lack of oxygen at the tissue level, unable to have the oxygen go into the cell where it's needed. So both of them cause a great problem and a grave problem. What's happening here to the patient is that they get extensive tissue destruction, and it causes this vast systemic inflammatory process. Now, we've talked about this inflammatory process and how deadly it is when the body just starts to freak out, and it leads to leaky capillary beds, and in this case, we're going to get a massive fluid shift, massive. And it is a severe systemic response, so they have a massive systemic response that lasts definitely for the first 48 to 72 hours. And this is characterized by large fluid shifts. So basically, you're looking at a patient that has a total body surface area affected of greater than 25% is going to have a massive systemic inflammatory process. When this fluid shifts from inside the vasculature to outside of the vasculature, that creates a hypovolemic shock. He no longer has volume in his blood vessels. So think about that for a minute, okay? You have blood cells, you have plasma, it's running through your blood system, right? Now, all of a sudden, the fluid portions and the cells start leaking massively. So they're going to begin fluid resuscitation immediately, and it's going to be based on the percent of the body that's burned, and they're going to monitor the urine output to ensure that they have an adequate amount of fluid going into the patient. At the same time, this patient is having pulmonary edema. He's going to start pulmonary edema. You've got this elevated metabolism with an increased CO2 production and O2 consumption and massive vasodilation. And so that's when pulmonary edema starts. And how do we treat it? PEEP, right? So we're on the mechanical ventilator. We're going to give him some PEEP. But we've got to be careful not to injure his lungs too much. Do you think we're a setup for ARDS? You betcha. And so some of the highest PEEP levels I've ever seen have been from burn patients. They can be difficult to manage when there's been a lot of airway problems, burn injury. So basically what you need to consider or know is that early intubation is always the best idea. If there's any remote possibility that there's been any damage to the upper part of the body, then the patient needs to be intubated immediately before those fluid shifts start. one, especially if the patient has a greater than 25% total body surface area burn, he needs to be intubated. You're going to monitor his oxygen saturation carefully, but remember, the oxygen saturation that you're monitoring may not be accurate in the presence of carbon monoxide. So you have got to do, listed here as co-oximetry, but the newer term is hemoximetry. You have to put it in and let the spectrophotometer actually look at the wavelengths and see how much hemoglobin has carbon monoxide on it. A fiber optic bronchoscopy may be necessary during the patient's length of hospitalization to remove any necrotic secretions that can block airways and cause atelectasis. And also, there could be necrotic tissue from the burn injury. You need to also maintain active heat and humidification because they've lost the ability to do it. And they're losing, remember that your skin is our barrier. Once you don't have that, you lose what's called insensible water loss. You have an increased loss of that fluid that even helps us to humidify our own gases as we breathe. So with that loss, we must put some more humidification or make sure that we have adequate humidification to every oxygen device that we deliver to the burn patient. So when delivering mechanical ventilation, you're going to initially need an FiO2 of 100% to establish his carbon monoxide level. And then you can get to an appropriate level to try to reduce the damage. So these patients can be very challenging depending on the percent burn. They also remain in the hospital for very long periods of time, and they go through a lot of surgery where they debride the dead tissue from the affected areas, and then they do skin grafting. So oftentimes the burn unit will have its own operating room there, and may even have their own hyperbaric chamber. I believe Duke has the ability to sterilize a room in their hyperbaric chamber area so that they're able to perform surgeries or take care of a burn patient that has a high carbon monoxide level. So those are considerations that are made for burn patients. And I've included a video that I would like for you to watch that really is very concise on the initial inspection of a burn patient. And that concludes this chapter. And I'll try to put within the next day, I'll put in a little review since it was so many different types of diseases that we've been talking about. So I hope y'all are doing fine and safe and well, and I'll talk to you soon. Bye.